Hello, today I am going to talk about diabetic neuropathy, or in pain management, it is painful diabetic neuropathy. So, what is diabetic neuropathy? Presence of symptoms and signs of peripheral nerve dysfunction in people with diabetes after exclusion of other causes. Then, diabetic peripheral neuropathy is common form of neuropathy, one of the most common diseases affecting the nervous system. Diabetic peripheral neuropathy affects greater than half of the diabetic patient with history of more than 25 years of diabetes. Diabetic painful neuropathy can lead to limb loss and death. Up to 50% diabetic neuropathy patient can be asymptomatic. Pathophysiology, why this happens? Direct toxic effect of glucose on nerve cells, accumulation of sorbitol, formation of advanced glycation products, free radical mediated oxidative stress, abnormalities in essential fatty acid, and deprivation of nerve growth factor. Microvascular dysfunction, damage to vasa nervosum due to thickening of capillary basement membrane. So, what is the role of sympathetic nervous system? Elevated level of norepinephrine in symptomatic neuropathy. Relatively high number of functioning sympathetic fibers contribute to pain. Impaired sympathetically mediated constriction contributing to inappropriate local blood flow. What are the types of diabetic peripheral neuropathy? There are divided into distal and symmetric peripheral neuropathy is the most common, 80%. Small and unmyelinated C fibers are affected. Thicker fibers that are more or less myelinated, A delta and A beta. Motor nerve fiber neuropathy, alpha fibers and motor weakness. Autonomic neuropathy, inflammatory neuropathy. So this is the picture showing neuropathy of thicker sensory fibers and neuropathy of small sensory fibers. So glow and stalking type of neuropathy. Then clinical presentation, most common is distal and symmetric type of, also called as length dependent diabetic neuropathy. Symptoms initially begin in feet and then gradually progress upwards. This is because longest nerve fibers are affected first. That's why the name length dependent polyneuropathy. Sensory defects can usually be observed in hands when the sensation around the knee is affected. Although there is an interval between few years between diabetes and neuropathy, this might be the first symptom of type 2 diabetes mellitus. Diminished sensation, burning feet, which may occur particularly during night and worsen when touched, and sensation of tingling in feet. Attacks of shooting pain also occur. Autonomic neuropathy occurs when there is involvement of autonomic nervous system characterized by gastric dysfunction, pupillary effect, renal function disorders. In examination, the neurological examination should include examination of quality of somatosensory function, reflexes, muscle strength. Then one of the signs of diminished sensitivity to pinprick along with reduced temperature sensitivity, decreased proprioception may be manifested as, for example, abnormal sensation of position of joints, toes, increased risk of falling, reduced pressure sensation, blunt two-point discrimination, or reduced vibration or allodynia and hyperphagia can occur. This is hair aesthesiometer for checking the pain sensation. Then investigation nerve conduction studies may show delay in conduction velocity, but can be normal if there is only small fiber involvement. Motor in early it is preserved, in advanced motor pathway is also reduced. In treatment, the main modality of treatment in a patient with diabetes diabetic neuropathy is improving glycemic control with use of diet, exercise, OHS and insulin. And neuropathic pain medications which include tricyclic antidepressant, selective norepinephrine release inhibitor, anticonvulsant and opioids. So antidepressants, most of the studies have shown that they are most effective drugs, limited by side effects. SNRIs, which include duloxetine in the dose of 60 to 120 mg, relief in more than 50% of the patient. Other drugs like gabapentin, pregabalin, and carbamazepine have been used. Then lignocaine patches in the distribution of peripheral neuropathy. Then IV lignocaine at 5 to 7.5 mg per kg given infusion over 4 hours at 4 weekly interval reduce the pain for next 15 to 20 days. Opioid study has shown that opioids are effective in diabetic painful neuropathy. Drugs like morphine, tramadol, oxycodone, combination of tramadol and paracetamol is as effective as gabapentin. They have their own side effects. Other treatment options are capsaicin cream for local application, antioxidants like alpha lipoic acid 600 mg IV for 4 to 5 weeks. This is the flow chart. If there is patient with painful diabetic neuropathy, depending on contraindication and comorbidities, we can use either anticonvulsant, that is alpha 2 delta agonist like pregabalin and gabapentin, then TCAs, tricyclic antidepressant, selective norepinephrine reuptake inhibitors. When the pain is adequately controlled and depending on contraindication and sometimes the side effects of the drugs, we have to continue either TCA or SNRI or alpha 2 delta agonist or TCA or alpha 2 delta agonist combination. If even after the multiple drugs pain is inadequately controlled, we have to go for opioid monotherapy followed by combination therapy when pain is still inadequately controlled. Then in interventional pain management, sympathetic nerve block may be effective like lumbar sympathectomy and slate ganglion block or T2 or T3 thoracic sympathectomy and spinal cord stimulation. Thank you.